Hello, my name is Michael Ritchie, and we're going to be talking about acid-base using SID, or strong ion difference. So in our objectives, we're going to say, is there a better way to do acid-base than what we're currently doing? We're going to discuss the Stuart method of acid-base, using SID when giving fluids during resuscitation, using SID when we're removing fluids for deresuscitation, kind of working up acid-base disorders, how to identify strong ion, exogenous acids, and then identifying special populations, and then go over some take-home points. Here's an example case. We have a 35-year-old male with a history of type 1 diabetes. He presented with shortness of breath and abdominal pain after running out of his medications. Blood pressure 105/67, heart rate 115, respiratory rate 24, SATI 99%, temperature 99.8. He's ill appearing, he's tachypnic, he's in mild distress. So it sounds like he's in DKA, right? So actions are going to be IV fluids, get some labs. As long as your potassium is high, then you can go ahead and start insulin. If your potassium is normal or low, you want to replace that potassium before you start the insulin drip. All this is pretty bread and butter whenever it comes to patients that you're going to see in the hospital or just a typical DKA patient. But let's look at the labs. He comes in, he has the pH of 7.23, so he's acidotic. You see that elevated potassium at 5.3. Bicarb's 15. Now you have an anion gap whenever you do it on there. His glucose is 457, ketone positive. It definitely sounds like they're in DKA. You go ahead and give them 4 to 6 liters of IV crystalloid, which is a very common amount of fluid that's given for a type 1 diabetic in DKA. And then you recheck in a couple of hours and they're down to an anion gap of 8. You're feeling super excited. Everyone's high-fiving. Sodium's 141 and chloride's 116. Now let's re-look at the labs. pH is about the same. Still acidotic, 7.25. Bicarb's is 17, so it hasn't really changed at all. What happened? Like, why aren't they better if you look at it on there? Their sodium was 132 and now it's 141. There's a difference of 9. Your chloride was 97, now it's up to 116. That's a difference of 19. Does it matter? So what we've done is we've taken somebody that had an anion gap metabolic acidosis and we've given them a non-anion gap metabolic acidosis. And this happens all the time in these patients and many other patients, is where you just change one acidosis for another. And people seem to be fine with this one. You still have a bicarb of 17, you have this really bad non-anion gap metabolic acidosis, and nobody seems to be as bothered by it than if you have an anion gap metabolic acidosis. But does it matter? You have your chloride went up by 19. You have this significant increase in your chloride that's led to this non-anion gap metabolic acidosis. Is hyperchloremia bad? There's association between the chloride liberal and chloride restrictive IV fluid administration strategy in acute kidney injury in critically ill adults. Hyperchloremia and hospital mortality in critically ill septic patients. Saline should not be your first choice of crystalloid resuscitation. Is hyperchloremia associated with mortality in critically ill patients? Hyperchloremia after non-cardiac surgery is independently associated with increased morbidity and mortality. The list goes on and on and on of all these different papers that show that hyperchloremia worsens outcomes. So now we're going to talk about the Stuart method of acid-base. So originally we talk about Henderson-Hasselbalch. So between 1907 and 1916, Henderson recognized that carbon dioxide and bicarb were used as buffers within the system. Hasselbalch did the negative logarithmic pH notation that we know, and we end up with this Henderson-Hasselbalch equation. Bicarb is one of the strongest buffers and determinants of pH. We've learned that. We had the great transatlantic acid-base debate in 1960 in Copenhagen. They used base excess, and it was introduced by Sigard and Anderson, and it separated the metabolic and respiratory components, and that became how we looked at acid-base. In 1963, Schwartz and Relman developed the bicarb-centered approach, and that was a relationship between PCO2 and bicarb, and that became the center of the Boston School. And so they would argue back and forth over which one would be the predominant way that we looked at acid and base. Whenever they first did the internal medicine books, is they actually decided that it would be too complicated to be talking about a negative base excess or a positive base deficit. That would be too confusing, and so they went with the bicarb-centered approach, whereas a lot of surgery literature did start doing the base excess approach. And so you'll see that people that have a surgery background are going to be a lot more comfortable dealing with base excess than people that have a more internal medicine background. They're going to be dealing more with the bicarb-centered approach. But it all just comes to the background between what was published in the books after this debate. The traditional methods, like where do they fall short? So the base excess method, it assumes that you have a normal non-buffer levels. And in the ICU, albumin and phosphate, which are also buffers on there, are often abnormal, and it doesn't take that into account. And it's hard to identify the different types of metabolic acidosis with base excess or base deficit, because all it's just doing is telling you that you have one. The bicarb-centered approach, there are non-bicarb buffers like albumin and hemoglobin that we talked about, and the equation misleads the dependence between PCO2 and bicarb as it determines the pH. So they have places where they don't exactly explain what you need to be explained. So we're going to talk about how the traditional methods don't have problems whenever you look at them. So the base excess method, it assumes that you have normal non-buffer ion levels, and that's not necessarily true in the ICU. And it's also hard to identify different types of metabolic acidosis, because what it's showing is that you just have an abnormality with your base excess or base deficit, not necessarily what's causing it. Versus if you in the bicarb-centered approach, again, they're not talking about the non-bicarb buffers that exist in our body, like albumin and hemoglobin, and it also will mislead the interdependence between CO2 and bicarb as determinants of pH. So 1978, Peter Stuart questioned these traditional approaches, and he talked about the independent and dependent variables and came up with the Stuart method of acid base, which is where we talk about the strong ion difference. There's two important concepts to understand when you're in understanding strong ion difference. You need to understand the difference between strong acid and base versus weak acid and base, and then the difference between independent versus dependent variable. Strong acids or bases completely dissociate. So if you look at hydrochloric acid, it's going to completely dissociate into hydrogen and chloride. Versus weak acids, they incompletely dissociate. So some of them are going to still be connected, some of them are going to be separated out. Carbonic acid is a great example, because you have your bicarb with your bicarbonate with hydrogen ion, you have your carbonic acid, but it also can go over to carbon dioxide and water. So there's double arrows on both sides. They can go back and forth on this, so it makes a big difference on how it works. Our strong acids and bases in the body, we have our strong cations, which are going to be sodium, potassium, magnesium, and calcium. And we have our strong anions, chloride, lactate, sulfate, acetoacetate, and beta-hydroxybutyrate. Weak acids in the body, we have bicarbonate, which will be talked about with carbonic acid. We have albumin and phosphate. Variables we're going to talk about, we have our independent variables. The definition of an independent variable is that it can only be changed from the outside environment. So if you have a patient that has hypernatremia, their body can't just start breaking down sodium because it doesn't want it. It has to rely on the outside environment or changes in order to reduce that sodium down. Versus a dependent variable, the body can make or break down and respond based on the independent variables if it's a dependent variable. So out of our list, the independent variables are all the strong cations and anions. It is some of the weak acids, so phosphate and albumin. And then partial pressure of carbon dioxide also fits into here. I'm going to kind of go over to it a little bit later, but it is also an independent variable. And then the only dependent variable is bicarb. Out of that entire list that we have, it's the only thing that the body can make or break down as much as it wants. And so Stuart's argument was, why are we focusing on bicarb? Bicarb is a response to all these independent variables. It's a dependent variable. If we look at bicarb, we're not getting an idea of actually what's happening. If we look at the independent variables, then we get a better idea of what's going on in the body, as opposed to just looking at what the body's response is to those. We talked about hemoglobin being a buffer, so it is a major component into being able to make or break down bicarb. It binds to hydrogen ions with the protein, or it binds to oxygen on the heme group. And so whenever one substance is bound, it kicks off the other one. So as it delivers oxygen to the tissues, as oxygen gets released, the hydrogen attaches to the protein, goes back to the lungs, and then oxygen comes on, it takes away the hydrogen ion, and then that's how it can make or break down as much bicarb as you need to. This is called the Bohr's model, and it shows how you can the body can make more bicarb or reduce more bicarb as it needs. So now we're going to talk about putting this together, understanding the old bicarb-centered approach and how it goes with the Stuart method. Is everyone knows about anion gap. Anion gap is going to be your unmeasured anions. I feel like people often say oh, does that person have an anion gap? Whenever they mean, does this person have an elevated anion gap? Everyone has an anion gap. They're just unmeasured anions. The anion gap is just the independent weak acids. The independent weak acids are phosphate and albumin. The phosphate is usually so low in a normal patient that it's not necessarily contributing to it. And so most of that unmeasured anions is just your albumin. So for every gram of albumin, you want to do about 2.5 to 3 on the anion gap. So if a normal albumin is 4, then you would say, okay, normal anion gap is 10 to 12 based on that. So whenever someone is saying, oh, they have a normal anion gap, what they're saying is they're associating that they have just their albumin that's contributing to their unmeasured anions. There's often a correction for your anion gap that people talk about. They say, okay, I calculated an anion gap of 10, but you have to correct for albumin. So you have to add 2.5 for every gram below 1. So if you have an albumin of 2, then you would have 5. You would say, oh, well, the corrected gap was 15. 15 is elevated because it's higher than 8 to 12. A normal gap is 8 to 12. Now, this gets you at the right answer, but it's a misunderstanding of exactly what is going on. What it's telling you is that people have different amounts of normal unmeasured anions. And so if someone's albumin is 2, then their normal unmeasured anion would be 6. It's not that you need to add to this unmeasured gap. You just to say, I calculated a gap of 10. This person's normal gap should be 6 because they have this low albumin, and what we're measuring is the unmeasured anions, which is the albumin. So it shouldn't be done this way. You should just realize that a person's normal anion gap is going to change based on what their albumin level is. So if they have an albumin of 2, a normal anion gap of 5. So if you calculate a gap of 10, that is an elevated anion gap. So if you're going to do this method whenever you're talking about deciding whether or not they have an anion gap metabolic acidosis, is understanding what a normal gap is. It's the unmeasured anions due to albumin and phos, but mainly albumin. So the laws of conservation of charge, the body tries to maintain homeostasis by maintaining electrical neutrality. So basically all the positives have to equal all the negatives. So on the positive side, you have sodium and calcium and magnesium and potassium. And on the negative side, you have chloride, all the other strong anions, bicarb, albumin, and phos. We've learned from all this that your albumin and your phos is your anion gap. We further looked at, multiple studies have said you can go ahead and just use your most predominant cation and your most predominant anion, which are going to be sodium and chloride, and you're going to end up with the anion gap equation, which is sodium equals chloride plus bicarb plus anion gap. So if you want to calculate an anion gap, it would just be sodium minus chloride plus bicarb. Now, for the Stuart method of acid base, it's saying that we are not going to pay attention to bicarb because the bicarb can just be made or broken down depending on the outside environments. And so we're just going to look at the strong cations and the strong anions. And so we're just looking at the difference between sodium and chloride. And it's just your anion gap plus your bicarb. So you're just adding bicarb to your anion gap. And that gives you a SID, or a strong ion difference, which equals sodium minus chloride. And only focus on things that the body cannot manipulate. So you want to look at the strong acids and the independent variables that are the strong acids. The difference in strong ions is the weak acid. So it's albumin, it's phosphate, it's bicarb. It's just anion gap plus bicarb. So again, your SID, or your strong ion difference, is sodium minus chloride. The normal sodium is around 140, and normal chloride is around 102. And a normal SID should be 38. And so whenever you look at this difference, you should get a number around 38. So looking at this Gamblegram, is what we see is that if we were to calculate the unmeasured anions, what we have is you have your bicarb, your unmeasured anions, that's going to make up your SID. You have your strong anions, and they all equal up to your strong cations. What drives our body's pH status? So if your SID is less than 38, that means you have more chloride than you would expect. So you have all this negatively charged chloride. The body says, okay, I have all this negatively charged chloride. I'm going to stop making bicarb because I have all this chloride, and you're going to end up with a non-anion gap metabolic acidosis. If your SID is greater than 38, then you either have more sodium than you would expect or less chloride, depending on how you want to look at it. But you have all this sodium that's not attached to anything, so the body makes bicarb in order to stay neutral, and so you end up with a metabolic alkalosis. So if your SID is less than 38, you have a non-anion gap metabolic acidosis. If your SID is greater than 38, you have a metabolic alkalosis. Bicarb is created or broken down in response to changes in SID. So as your body is being changed by these independent variables, the bicarb is going to change because it's the dependent variable with it. So focusing on what the differences is in the independent variables makes more sense than looking at the dependent variable. All right, if you look at it in the Gamblegram standpoint, as that strong anions start getting higher and higher, the body has to somehow get rid of something in order to stay neutral. And so what it gets rid of is the bicarb, because it's a dependent variable. So you can see that bicarb get less and less and less as that strong ion concentration goes higher and higher. And you end up with a non-anion gap metabolic acidosis. So why the Stuart method? Why use this method? The bicarb-centered method is reasonable, but I feel like it limits our understanding of the acid-base physiology. So one example would be, all right, you've given this patient 3 liters of normal saline. How will it affect the pH status using your understanding of the acid-base bicarb-centered approach? And so people will say, oh, it dilutes out the bicarb, but it also dilutes out the hydrogen ions because it's just sodium and chloride. Whereas if we focus on the bicarb, or maybe don't understand it, whereas if we try to look at what's actually happening to the body using the independent variables, I think it makes a lot more sense. So if you look at it in terms of strong ion difference and the Stuart method, I think it'll have a little bit better understanding. So we're going to start out with just 1 liter and 1 liter. You have 1 liter of plasma, so you have 140 and 102 with a SID of 38, and you have 1 liter of normal saline. So you have sodium of 154 and chloride of 154, which has a SID of 0. So it's extremely, extremely acidotic. And if you mix these together, they're going to be 1 liter and 1 liter. You're going to end up with a SID of 19. So that's a really significant non-anion gap metabolic acidosis because you're diluting down that difference from 38 to 19. If we use the whole body, we're going to look at extracellular sodium content. So average sodium of 140, you're looking at 15 liters of extracellular fluid. That's going to give you about 2,100 milliequivalents. We're going to use a serum chloride of 100 for this example for math purposes. That's going to give you about 1,500 milliequivalents. And then that will give you a SID of 40 for this patient. Now, bicarb we're going to assume is 25. And we're going to add 3 liters of normal saline. Now we added 462 of sodium and 462 of chloride, and now we're up to 18 liters of extracellular fluid. So 18 liters of if we divide that out, our sodium goes from 140 to 142, not a big change. But our chloride goes from 100 to 109. So it goes up by 9 versus 2 because it has such high chloride in normal saline. And that drops that SID to 33.3 and it drops the bicarb to 18. So now you've given them a pretty significant non-anion gap metabolic acidosis just by giving 3 liters of normal saline. So if somebody comes in with a bicarb of 18, you're going to assume that they're pretty sick. But now we're just giving people bicarbs of 18 because we're giving them normal saline whenever there's a lot of other options out there. So what does it mean clinically? So in resuscitation fluid, what we want to do is, the idea is that if we give somebody a fluid that decreases the patient's SID, it will decrease their pH. It will make them more acidotic. If we give them a fluid that increases SID, it will increase their pH. It will trend them towards more alkalosis. Here's some fluid examples. So normal, we talked about, you have a sodium of 140, you have a chloride of 102, you have a normal SID of 38. Now, normal saline has 154 and 154. That gives you a SID of 0. So you can see how extremely acidotic it is. Lactated ringer, when you add up all the positives and negatives, you end up with a SID of 28. And then with Normasol and Plasmolite, you end up with a SID of 50. Your lactated ringer has the lactic salt of 28, and that's where you get the SID of 28. And then in Normasol or Plasmolite, you have acetate and gluconate, and that has 27 of acetate and 23 of gluconate, which is where you get the SID of 50. So lactated ringer is a little bit on the acidotic side. Normasol and Plasmolite are a little bit on the alkalotic side. So normal saline has a SID of 0 and is extremely acidotic. Lactated ringer has a SID of 28. And then Normasol has a SID of 50 due to the acetate and gluconate. They're all broken down eventually into bicarb. But what it is it gives you, it has that ability to separate out your strong cations and strong anions. And so the body's going to respond to that spreading out of that sodium and chloride by making more bicarb. A little bit of added complexity just to show you that it exists. It's not super big deal, but anytime you give somebody crystalloid, you are diluting out their albumin a little bit. Albumin is negatively charged, so you make them a little bit more basic by just giving them crystalloid because you're diluting out the albumin. So if you were to design a fluid that had a SID of exactly 38, it would actually be a little bit more basic because of that slight dilution of your albumin. Here's all the fluids and what the SID is. So normal saline has a SID of 0. It is very acidotic. Anything that has a derivation of this, so half normal saline, quarter normal saline, all of that has the same difference between the sodium and the chloride, so it trends towards acidosis. Water trends towards acidosis. It has the same amount of sodium and chloride. Lactated ringer is 28 that we talked about. It's fairly neutral when you account for the alkalosis. Normasol is 50, and you get some additional dilutional alkalosis. Anything that's albumin will trend towards acidosis, so 5%, 25%. Hypertonic saline is obviously very acidotic. And then if you were to do a bicarb drip, isotonic bicarb drip, it's typically 3 amps of bicarb and 850 of either free water or D5W to give you a liter, and that would have 150 of sodium, 0 of chloride. It'll give you a SID of 150. It's extremely alkalotic. How do all these fluids work with base excess, right? So if you're more comfortable looking at it from a base excess standpoint, the definition of base excess is actually fairly complicated. It is the amount of strong acid that must be added to each liter of fully oxygenated blood to return to a pH of 7.4 at a temperature of 37 degrees and a PCO2 of 40. Here's what all these different fluids do to your body's base excess or base deficit over time. So you're looking at up to 10 liters. So normal saline is at the very bottom, and you can see how acidotic somebody would give if you just keep giving normal saline, normal saline, normal saline. Whereas if you give just pure bicarb at the very top, you're going to get more and more alkalotic. And then as you look at some of these other options, they're going to be closer to what you would expect towards neutral. So ringers, lactic, plasmolite, they're going to lead you more towards a little bit of alkalosis with it, or normal to slightly alkalotic. Is lactated ringers bad, right? It has lactic in the name. People are worried about it. But it's actually lactic salt, not lactic acid. So it's not going to give you a lactic acidosis. It just has the lactic salt in it that's just going to be broken down into bicarb. All right, so why do we give bicarb solutions? Like, what is it the bicarb that makes them alkalotic, or is it just because of the lack of chloride? And in fact, it doesn't matter that we're giving them bicarb. The presence of bicarb, if we get bicarb, doesn't contribute at all. It could be acetate, citrate, gluconate. All that matters is that you're giving sodium without chloride. And so by increasing that sodium without increasing the chloride, the body responds by making bicarb. It's contained, actually, whenever you get it. Bicarb is contained in glass vials. And the reason for that, the reason you can't just go grab a liter of bicarb is because as soon as it's out of the pressurized glass bottle, it starts immediately turning into CO2 and water. And so whenever you push that bicarb, you're getting that increase in sodium. But then what's happening is that all that CO2, all that bicarb just turns into CO2 and they breathe it off. So you're not going to get any benefit from a bicarb standpoint. It's all just from the sodium with lack of chloride. So if you're going to use SID with fluid resuscitation, you want to choose your IV fluids based on the patient's SID. So if their SID is greater than 38 and they have a metabolic alkalosis, you can give normal saline. It's fine, but as you give 1 liter, 2 liters, 3 liters, it's so acidotic that it's going to start trending you towards acidosis. Whereas if you're already acidotic, if you give somebody something that's acidotic, it's going to make them worse and worse. I like to give normal solar plasmide in this situation. The reason that I usually end up giving it is that all this stuff that's mixed in it. So you have your like I said, your vancomycin, your zosyn, your electrolytes, your pressors, a lot of them are going to be in acidotic solutions, so usually mixed in normal saline. So everything you're getting is trending towards that acidosis. And if you give lactated ringer, it's going to kind of just keep it at whatever level it's at, versus if you're going to give normal solar plasmide, it's going to trend it towards alkalosis to kind of help offset all the acidotic stuff that you're giving with all the diluents. So chloride in normal saline, we mentioned this before. Why is it bad? It's associated with worsened mortality with acute kidney injury. So the chloride itself causes a non-anion gap metabolic acidosis, and the high chloride causes constriction of the vasculature in the kidney and will lead to acute kidney injury. So all of these studies are showing worsened mortality and worsened kidney injury because of the high chloride levels. It's associated with mortality and septic shock. It shouldn't be your first choice. It is in non-cardiac surgery. Again, it's associated with increased morbidity and mortality. In 2022, what it showed was that there was a high probability that balanced solution use in the ICU reduced 90-day mortality, especially if they were given balanced solutions pre-ICU, like in the emergency department. And so you can see how just giving them 1 or 2 liters of normal saline in the emergency department is just it's gonna cause problems even further down the road, because it's going to trend towards a lot of that acidosis because of everything else they're being given. Another review that did a systematic review and meta-analysis showed that the balanced crystalloid had reduced overall mortality, reduced 30-day mortality, reduced acute kidney injury over normal saline. In the 2021 Surviving Sepsis Guidelines, the new guidelines that came out, they actually upgraded their recommendations, and they said that balanced crystalloid should be used over normal saline. They gave it a weak, low quality of evidence. Now, if you're going to say, all right, I'm not going to do this because it's only weak, low quality of evidence, I want to see more evidence before I'm going to go down this road. Just keep in mind that giving 30 mLs per kg, which is what everybody does in septic shock patients, has the exact same level of recommendation. It's weak, low quality of evidence. So if you're going to be giving somebody 30 mLs per kg on this same data, then you should be giving balanced crystalloid. It's now in the recommendations, has the same quality of evidence as 30 mLs per kg. There are arguments to giving it. Arguments that I read is that I read a study that it doesn't matter, and there are studies that cross the midline and say, all right, We can't prove it trends towards balanced crystalloid, but it does cross 1. So we can't say that it actually causes a benefit. There are many papers that show that it does, that balanced crystalloid is better. And so everything trends towards balanced crystalloid being better, especially if you do it throughout the whole stay. So many of these studies, once they got to the ICU, they got changed into either balanced crystalloid or normal saline. Whereas if you look at a study where it actually shows that they got balanced crystalloid in the emergency department all the way through, then they definitely had an improved mortality through there. So it's important that they're getting it all the way through the entire stay, and that's where you're going to see those benefits. Because again, everything else that they're being given is trending them towards this non-anion gap metabolic acidosis. The other one is the cost is too high, right? Everyone's like, oh, it's so expensive. The hospital won't pay for it. It's way too expensive. So at my previous place I worked at, normal saline, lactated ringer, and Normal were all around the exact same price. At the last time I checked, it was normal saline was $164, lactated ringer was $150, and Normal was $3. So where I'm currently at, it is $1.36 more. But if you're talking about improved mortality, reduction in acute kidney injury, less likely to be on renal replacement therapy, all for $1.36, I think it's worth the increase in price. The next argument is hyperkalemia. People say, all right, well, lactated ringer and Normal contain potassium, so it's going to worsen somebody that has hyperkalemia. And it's true that lactated ringer and Normal have a little bit of potassium in them, between 4 and 5 milliequivalents. But if you think about the fact that if someone has a potassium of 6 or 7, if you're giving them a solution that only has 4 or 5, it's still going to lower the potassium down because it's a less concentration than what the patient has. Additionally, what we've learned from DKA is that K follows H. So whenever you have something that's acidotic, is that you're actually going to pull that potassium into the serum, and it's going to have a higher potassium level from the acidosis. And then as you start correcting the acidosis, it'll bring that potassium down. So Palm Crit with Josh Farkas actually did a really good blog that talked about myth busting, or lactated ringer is safe and hyperkalemia is actually superior to normal saline. And the reason for that is because normal saline is so acidotic, it actually pulled potassium into the serum because of how acidotic it was. And so after they got this fluid, it had a higher potassium level with normal saline than it did with Ringer's lactate. So you can see here on this table is that in the lactated ringers group is that it had a higher bicarb level, it had a lower potassium level, and a lower chloride level because of the significant chloride in the normal saline that increased the acidosis and worsened the hyperkalemia. So it's safer to give normal salt, it's safer to give lactated ringer than normal saline in people with hyperkalemia. How do we use SID when diuresing? So any diuretic that decreases the patient's SID decreases pH. Any diuretic that increases the patient's SID increases pH. So if we think about it from a diuresis standpoint, we look at loops and thiazides, is that if they're all sodium channel blockers. So if you're blocking sodium, you're gonna remove sodium, but it's going to be attached to chloride, which is not going to make a difference. But they are potassium wasting. So the potassium is going to get excreted out and it's going to be attached to chloride. And so you're going to be losing more chloride than sodium. And because of that is that it increases the SID in the body. The difference between the sodium and the chloride is going to widen in the body. And this happens for everybody. If you give somebody enough loop diuretic, or if you give them enough loop diuretic over time, everyone will widen out their SID. Everyone will trend towards an alkalosis. And oftentimes it gets mistaken as saying, oh, they have a contraction alkalosis, and people want to stop diuresing them even though they're still very much volume overloaded, because they'll say, oh, their bicarb keeps going up and up. They must have a contraction alkalosis. We've over-diuresed them. But in fact, it has nothing to do with that. It's just a body's response to losing chloride. So I like to call it an iatrogenic alkalosis because we're doing that because we have them on a potassium wasting diuretic. So if you want to keep diuresing them, what you can do is just give them something that is going to continue diuresis, but it's going to narrow that SID so that it's not widening out as much. And then that example would be like a carbonic anhydrase inhibitor. Acetazolamide is a good example for it. and you're removing sodium and not chloride. So yes, you're going to remove sodium attached to bicarb, but your body can make or break down as much bicarb as it wants. So it has nothing to do with actually removing the bicarb. It has everything to do with just removing the sodium and not the chloride. So as you start removing all that sodium in your body, the difference between the sodium and the chloride narrows, and you start trending towards more of an acidosis. So if you need to kind of narrow that SID, if you're trying to if you're getting more and more into the alkalosis, by giving a carbonic anhydrase inhibitor, you're going to narrow that back down to where you want it, so you can keep diuresing while still normalizing what their SID is or their acid-base status. So if you're going to choose a diuretic, if they're alkalotic, you can give a carbonic anhydrase inhibitor, and if they're acidotic, you can give a loop or a thiazide because it's potassium waste and it's going to widen out that SID. So at the end of diuresis, at the end of deresuscitation, ideally you want them to have all the volume off. You want them back towards euvolemia, and at the end of euvolemia, you want them to be able to say that they have a normal acid-base status, they have a normal SID, so you haven't caused another problem in the middle of your deresuscitation. So working up acid-base disorders, anyone with a SID less than 38, they're going to have a non-anion gap metabolic acidosis, so high chloride, acetazolamide, renotubular acidosis, diarrhea are going to be the main ones. Anybody with a SID greater than 38 is going to be a metabolic alkalosis. Diuretic therapy, gastric secretion loss, post-hypercapnia, those are also very common in this situation whenever you're trying to work up somebody that has a widened SID. Now, exogenous acids, right? So all this has to do with acid bases within the body. How do you account for the exogenous acids that are be putting in? And then, so instead of anion gap metabolic acidosis calculation, where you're calculating that anion gap, is you can actually calculate what's a strong ion gap. And it's a more complicated formula. So you're going to get base deficit plus SID minus 38 plus 2.5 times 4.2 minus your albumin minus your lactic. And if it's greater than 2, then you have this exogenous acid, this kind of anion gap metabolic acidosis. And then you can do mud piles or Goldmark, whichever one you prefer, to kind of work this up. Clearly, this is a more complicated equation than just doing anion gap. I typically will just do the regular anion gap if I'm looking for it, because I don't always have all this information to be able to calculate a strong ion gap, but it has been shown to be very helpful whenever looking for exogenous acids in the body. And you don't need to do a delta-delta. And I think people oftentimes, they get very intimidated by looking at it, and they say, all right, they have an anion gap metabolic acidosis. And they said, well, now we need to do a delta-delta. Do they have a concomitant non-anion gap metabolic acidosis? Do they have a metabolic alkalosis? And so instead of doing that delta-delta, you just do the SID. If your SID is less than 38, you have a concomitant non-anion gap metabolic acidosis. If their SID is greater than 38, they have a metabolic alkalosis. I do want to identify one special population, and that's the chronic hypercapnic patients that are chronically retaining CO2. So it is an independent, strong acid, and it's going to lead to a chronically reduced chloride. It's going to lead to more elevated bicarb, and it's going to make their SID higher than than normal. So the SID of 38 is under the assumption that they have a normal PCO2. If they have a chronically elevated CO2, their normal SID isn't going to be 38. It's going to be 42, 43, whatever number you decide that it is. And what it means is that people get very scared about correcting theirs, like, oh, we shouldn't give Diamox, or we shouldn't give acetazolamide or carbonic anhydrase inhibitor, because what it's going to do is it's going to make people acidotic. But as long as you feel comfortable knowing what their baseline SID is that we would have a patient that has obesity hyperventilation syndrome, and they have chronic retainers, and they get volume overload. We start diuresing, they end up 10, 12, 15 liters negative. All of a sudden, their normal SID, which is 42, is now closer to 50, and their bicarb, which is normally sitting around 30, 32, is now closer to 40. And so now they're like, oh, they have a contraction alkalosis when they're still volume overloaded, or they're apprehensive to give them a carbonic anhydrase inhibitor because they don't want to send them into an acidosis because they're chronic retainers. And as long as you know what that baseline SID is, you can give a carbonic anhydrase inhibitor and bring them back to a baseline SID. You just don't want to normalize it to 38 because that's not their normal. Their normal is somewhere higher than that. So again, no need to normalize to 38. They have a new normal, so you want to normalize them to whatever you feel like their normal SID is. Take-home points, how to prescribe fluids appropriately. You want to give balanced solutions, I think, should be given as the default fluid. I just don't think you should be giving normal saline. The reason for that is that so much stuff is being given that trends you towards a non-anion gap metabolic acidosis. So by giving balanced solutions, we've shown that if you give balanced solutions in the emergency department, in the ICU, is that will improve mortality, improve your or reduce your risk of acute kidney injury, especially with large volumes. Use the Stuart method whenever you're trying to resuscitate. You want to maintain a physiological SID. You don't want to say, oh, I fixed their anion gap metabolic acidosis, but now I've given them a non-anion gap metabolic acidosis. And it happens all the time. You say, well, I fixed this problem, but then you gave them a new problem, and you say, well, it's not as big of a deal. A non-anion gap metabolic acidosis with a bicarb of 16 isn't as big of a deal as an anion gap metabolic acidosis with a bicarb of 16. And I would argue that it still is not good for the patient and can worsen outcomes. And then how to prescribe diuretics appropriately. So again, use the method of acid base. You don't want to deresuscitate somebody and then at the end of deresuscitation, they have a significant alkalosis or a significant acidosis. So by using that strong ion difference and using the Stuart method of acid base, you can kind of alternate back whatever diuretics you need, so at the end of that fluid removal is that they have a normal acid base or normal SID. Don't be fooled into saying contraction alkalosis. If they're still volume overloaded, they have an iatrogenic alkalosis from the loop diuretic, and that you can just add your acetazolamide or something that's going to help while you're still removing fluid, but help reduce that SID back to normal. Know the baseline SID if they're chronically ill, and then try to correct their normal SID if they're a chronic retainer. And here are my references. Thank you very much.